Hello. So it's
Okay,
2 o'clock. Christina.
okay, welcome everyone. A very good afternoon, Home Nursing Foundation's webinar. And this series is the second installment of our sharing on InterRAI for community aged care physicians. I think I've been sharing about HNF for a long time now. So today I just wanted to go a little bit more about why we do all our services: home medical, home nursing, home therapy, home personal care, and also have 2 senior care centers and 1 active aging center in Buangkok and Hougang. We wanted to share with you why we wanted to do this series of webinars, because we hope that by sharing all this knowledge and experience, we can provide better care and we can empower all our patients and their families to be living joyfully and aging joyfully in the community. And also want to also give you a special peek into what's coming in October, 11th of October. Please set aside your Friday for our Age Well Symposium that will be held at HDB Hub at the Atrium. And we will also be having a very interesting lineup of speakers. It will be a free event for all of our community partners, as well as an afternoon where our seniors, if you run an active aging center, if you run a senior care center, please took your seniors time to come and take part in a very interesting tournament or a talent time with prizes and trophies. So without further ado, I will pass our time to Dr. Ng Wai Chong, our medical director and heading our clinical developments. We hope that through these sessions, you will also get to know one another better, and we can form partnerships to help do care referrals and coordination for patients who are frail under your care. And if they need home care and end-of-life care, please also remember to use this InterRAI assessment, and also contact us. We can help you to do the referral and assessment as well. Okay, over to you, Dr. Ng.
Thank you, Christina. Okay, so yeah, today is my turn to give a lecture on making sense of InterRAI assessment. Unfortunately, Faiza is attending a wedding, so she can't join us, but she'll join us once she's done as a panelist. So I will ask her to comment on how to read the InterRAI as well. So well, I have been like talking about InterRAI for quite a while, and creating a lot of enemies, frenemies along the way. So I think many of you here have heard me like talking ad nauseum about this very, very long-winded and complicated tools and so on. But actually, I must tell you, it's all good intention. I was very interested in this because I felt imbalanced whenever some bosses of mine, ask me to see patients once every 2 months or once every 3 months. I say, where does this come from? Where's the evidence base for this? So I wanted to have something to really give us some evidence base. How frequent is enough? Too much or too little? What is over-servicing? What is under-servicing? So around 2005, thanks to Dr. Tan Boon Yao of St. Luke's Elder Care, St. Luke's Hospital actually, he invited an eminent geriatric professor from Melbourne to Singapore, and then at that time we have this home medical care network. A few organizations. HNF was one of them. South Foundation, Code 4, and Touch Home Care. So we are supposed to co-host Professor Sam Sugar, and then the purpose was to, among the home care doctors, we just think that how do we create a standard? How do we know what is over-servicing, what is under-servicing? How do we ensure the quality of practice? So that was our challenge to Sam Shearer. And he said he didn't know, but he presented to us the InterRAI system. And that was like, it was really flying all over our heads and really quite difficult to understand. But fortunately, I studied his slides and I felt that there's something interesting about it, about standardizing the way we do the assessment. Because at that time, all of us use different kinds of tools. We were fresh from geriatric wards, GD, GM, and so on. So we are all, very, very excited about aged care. But before I was in community care practice, I was running a GP clinic. So I spent a long time doing comprehensive assessment, only to realize that actually as a solo doctor, you're actually quite helpless and almost useless, but it's not really useless. Now I know better. Doctors is very valuable, but there is more than just medicine that we have to apply. So my experience as a GP in home care in this, and so I studied this particular instrument, and it's really a long road. It's not easy to do, and so I'm glad that I mean not glad in the I mean yeah, I'm just happy that there is this recognition of an importance of standardized assessment, especially in the face of aging population. So today I shall share with you, as a doctor, I mean, it must be quite threatening to think of this assessment. Maybe you democratize medicine or democratize geriatric assessment and so on. There is still a lot of role and a lot of value for a doctor. I just want to share with you how this can actually make our work better, easier, and more equitable. And yeah, so I have a long lecture, so I shall not be talking too much, but it's really good intention that that we are looking in this particular assessment instrument. So I'll be sharing in this particular topics. Now, first of all, I want to just let us think about what we're currently practicing now in terms of comprehensive geriatric assessment. And I'd like to talk about geriatric assessment using InterRAI. And I will go into the details of how do you read the scales. The scales are divided into 5 groups. The biophysical health, you know, all your nutrition, all your what else, false risk, and so on. And then you have cognitive and emotional health, your depression, your cognitive function, functional ability, social life. And then there is a whole list of scales useful for risk stratification. So those of the audience here who are involved in population health, you know this is really important for the equitable, inclusive, and accessible resourcing, you know, for a massive population with aging and frailty, and caregiver are very stressed, and you can't build hospitals fast enough. So these risk stratification skills can be very useful for us. Then I'm going to summarize everything into a cheat sheet, okay? And then we have a quiz. So that I will summarize and share with you what I think the role of a doctor is in the face of all these way we are approaching frail care. Okay, so just a reminder, this is our national frailty policy, the 3-tier approach, whereby those who are CFS 6 or higher, and those who are CFS 4 and 5 with ICOPE screening positive, it is recommended to do a CGA, comprehensive geriatric assessment. So what are CGA? So CGA are actually comprehensive assessment, focus on the function, but function is, of course, dependent on the physical health, particularly the type of diseases the person has. Also the medications, as well as the psychology, the motivation. I mean, many of us in home care enough, you know, there are some people who are really not homebound, but because of their demoralization, their depression, their anxiety, they are homebound. Okay, so psychology, mental health influence the function, as well as social, whether there's someone to bring them down to see the GP, or there's no one, or there's financial barriers. So these are social determinants, as well as environmental. Like many years ago in Chinatown Plaza, 7th floor, no lift landing, the person on walking frame is homebound. Then we have to see. Then gradually they started to upgrade all the places, and then they start to have lift landing. Then they become not so homebound. Then gradually with all the SEC, IHDC, and so on, the home care patients become more and more bed-bound rather than homebound. So the environment has an impact on the function. And finally, spirituality. Now, spirituality, a lot of time you can treat pain, treat depression, and so on, but no medicine can work. And there's something else that is actually in the person's psyche that we are, a lot of us as doctors, nurses, social workers, we can't really quite engage this, and that's the part. So what do we normally do for CGA? So most of us, we actually have a template in our mind. I mean, when I was a GP, when I do home care as a solo doctor, I'll have this in my mind, no? Biodata, medical background, there'll be list of chronic diseases or any acute major medical events. So the discharge summary from hospital is very useful. But occasionally you have some of those very neglected seniors. They haven't touched a hospital. So you don't have a discharge summary to cut and paste. So you will still have to go through this. Then you have to review the medication because medication have huge importance on the function. ADL, IDL, of course, and then cognitive function, mood, and social. Social, I usually like to draw a genogram. But sometimes, you see the NHR drawing genogram is very inconvenient. So they say, how many room flat, living with whom, is there a maid, is a family caregiver stress or not? That's how we do a very simple social assessment. And then as, working in geriatrics, we know lah, if you don't ask, they won't tell you. Pain, nutrition, appetite, weight, PU, BO, falls, vision, hearing, cardiorespiratory symptoms, health screening, vaccination, and dentition. So we will go through that. And finally, we use a list of assessment tools because we want some kind of psychometric objectivity, right, to assessing things. And I remember when I was in geriatric ward in AHR, I was very, very inspired because I feel finally I can be like a very holistic healer. Then I have a little booklet to measure all the AMT, sometimes MMSE. And then a few years later, I heard from a professor from New York City, Mini-COG, which is much easier to use, and MOCA, which is more specific. And we also use strategic depression scale. And then there's my colleague who is family medicine consultant. He used PHQ-9. And then more recently, I heard the nursing home using EBUS. And of course, Bartel Index is widely practiced. Everybody use it. But when I was learning geriatrics, we use CUTS Index. And then also a lot of the therapies, they use FIM because FIM is actually more granular. You can see the improvement in the function. And Lawton, we don't use it so much. We just give a list of IDL. But when I'm working with community case managers in Indonesia, Mongolia, we use Lawton because they want to use something that's widely published. And of course, there are many others. Delirium, you have to use CAN. Nutrition, mini nutritional assessment. And my experience with this is all frail elders are at risk of malnutrition. So it's as good as not doing. Behavioral concern, when I was working with Philip in Alexandra Hospital Geriatric, we use NPI. Then when I was doing research on community dementia, I used RMBPC. And there was this Cohen Mansfield, who is a professor in dementia when she was in Singapore. I heard her talk about the Cohen Mansfield inventory. And Fred score, the interesting thing about Fred score is that it's very non-standard, different version of Fred score. And then caregiver stress, Zerritt burden interview, everybody is using it, and there are many versions. 6 items, 5 items, 12 items, and many other items. Pressure ulcer avoidance scale, pain, visual analog or verbal numeric. So for me, verbal numeric is very easy, but if a person cannot speak, then I'll use PainNet. So we have a lot of these skills. Prognosis, Karnofsky performance scales, palliative performance scales, and there's also a hybrid of the two. So when we're doing end-of-life care, this is quite useful for titrating the degree of stability of the case. Quality of life, usually we do only research, EQ5D, self-rated health, and then frailty. I talked about this the last time. There's frail scale, there's SAC, there is Fried index, there's time up and go. SAC is more for sarcopenia, but they are all like linked because frailty is about phenotypic frailty or the cumulative deficit frailty. So all these are broadly used. And Singapore has a case mix system for a long time, the RAF, which we use it to go by for nursing home subsidy. But when we apply RAF in home care, it doesn't quite work because RAF, the time motion study was tested in nursing home, not in home care. So in home care, you can't tell what kind of patients are, how expensive is it to support. From community doctors, there are people who are able to walk, but they are very malnourished, very depressed, no family or family is all dysfunctional. That is more complicated than somebody who is bed-bound with a team of loving family, well-to-do, and so on. So case mix is not so easy. So after the comprehensive assessment that traditionally we do, what do we do next? of course, we come up with a problem list, so you'll find that internal medicine, the orthopedics, the geriatrician, they have different kind of way they focus on problem list. So you can see if you're working in geriatric patients, you're quite concerned about psychosocial dimension, so about dementia, depression, PTSD, career stress, and so on. And the thing is, a lot of time you'll find that you can have a very elaborate problem list and care plan, but you may miss the most important in the picture, which is the patient. And the second, and perhaps equally important, is the family caregiver. So this is the part that sometimes we actually don't quite meet, the unmet needs, and sometimes you're frustrated. How come you're not compliant? How can you never come to hospital? How can I never go for SOC? Because you haven't really quite got what is important to the person and the family member. So that is how we do the care plan. Now let's talk about InterRAI system. So InterRAI, today we want to talk about what to make sense, right? So you need to know a little bit of the mechanisms. This one, Sister Faiza did it about 2 weeks ago. So I'm using a different rendition. So you can see you input clinical assessment. So usually the nurse or the allied health professionals, and in Canada, I noticed that they trained mid-career people who switch to do assessments. So you don't have to be a nurse or even a social worker. You can be trained to do this. So they do the assessment, they enter the data into the technology platform, and then there's an algorithm that's built in. It is it's highly evidence-based. And then to produce to the left-hand side, you can see the clinical assessment protocols. These are the care foci that make a difference to the patient. To the bottom is clinical status scales, which I'm going to talk about today. And then you can also produce quality and case mix. So these two are for clinicians, okay? For the agency chiefs, the CGOs, and maybe the payers, such as the government or insurers in the future, they are more interested in the case mix and the quality indicators, right? If I want to govern the system to make sure that nobody is shortchanged. So for clinicians, today I'm going to focus on how do you read the scales, so that you read it and you roughly know what kind of patient you're seeing. And on the 1st of June, I'll be covering the care foci. So back to the CGA. So you can see a typical CGA has got medical and medicines use, functional, psychological, mental health, social, environmental, and spiritual. So if you, in the home care, in home care setting, like in HNF, we do home care. And then if you're a CCMS, the Community Care Management Service, which is also island-wide, you also use InterRAI HC. And if you're running a SCC, and if your clients are usually, quite complex, it is still good to use a HC. So I'm only focusing on home care today. If you do home care, InterRAI home care, there is another version of InterRAI which is shorter called InterRAI checkup. You more or less you can interpret checkup already. So I'm focusing on home care. Otherwise, my lecture will be very long. So let's analyze home care suite. Medical and medicines. It's covered in section H, section I, J, K, L, and M and N. It covers continence, diseases and diagnosis. All the common diseases you can think of, it is there. Okay, so you can use that to capture very useful data if you want to mine the data. Health conditions would be things like giddy, vomiting, breathlessness, all these conditions. The systems review is covered. Oral and nutritional status is covered, including dentition. Skin conditions, including the risk of ulcers, rashes, diabetic foot is all covered. Medications, previously we had to enter all the medicines with the frequency and the doses, but now, since a lot of us complain, InterRAI has shortened it. Basically, just need to count the number of medicines. More than 8 is considered a risk of polypharmacy. So list of medicines, treatments and procedures. I mean, frail elders, many of them receive maybe peritoneal dialysis, maybe physiotherapy, maybe nasogastric tube, maybe tracheostomy. So we will also want to capture those things. So this is a medical side. And then on function is a huge section called the section G, function status, or mobility to ADL to IDL. Then there's the overall status. And then in section C, D, and E are cognition, communication and vision, mood and behavior. And then on section F, O, P, and Q are the psychosocial well-being. Responsibility include whether you've done your LPA, whether have you done your ACT. So it's covered in InterRAI HC. Social supports, there's a huge section in home care on informal caregivers. How many informal caregiver 1, caregiver 2, how much time they spend? Do they feel overwhelmed? Do they feel depressed because of? So you actually have an extensive social assessment also. In long-term care facility version of InterRAI, you don't have this part. Okay, environmental assessment also only in home care. So you talk about whether the house is squalid, hygiene, accessibility, crime, and risk of crime, and for risk. And so they do the environment assessment as well. And of course, you have all the biodata, discharge, and so on. Sorry, no spiritual assessment. Okay, so this is a part that InterRAI is lacking. And based on this assessment, there are some scales. So you can see the biophysical health scale. We have a pain scale. We have a pressure ulcer risk scale. Sorry about the abbreviations. When I explain deeper, I will not use the abbreviation. But because of the design of the slide, I use abbreviation BMI. Then in the functional side, they've got a long list. ADL hierarchy, H, ADL long form, ADL short form, communication, deaf-blind, index, okay, and then functional hierarchy, IDL capacity, IDL performance. I will explain these in detail later. Okay, then we have got the psycho-emotional scales. ABS stands for aggressive behavior scale. CPS stands for cognitive performance scale. COM is a communication scale. DRS is depression rating scale. And then under social, there's only one scale, which is the caregiver risk evaluation. The risk of this caregiver burnout. Okay, so it's captured. And of course, there are those very useful tools called the risk stratification tools, the CHESS, the MAPLE, the DIVERT, and the VPR. So today we shall learn how to interpret these scales. Okay, status and outcome scales. So in the so what are status and outcome scales? Basically, it's a measurement, you know. You can actually, there are certain cutoff beyond which this is a risk, or there are no cutoff. You use it to measure pre and post, and whether your intervention improve on the pain, improve on the depression, improve on the function. So you use the scale as a measurement. Some of these scales will not change. I mean, you take care of frail elders, the cognitive impairment won't, I mean, if they got dementia, it won't go back. It won't get better, it just get worse, whether it slows down or not. So some of these scales are not responsive to treatment. But some of these scales impact on what is the cost of care. So these scales are all very useful and actually very interesting. So, and all of them have been validated against the gold standard, you know, like MMSE and your Hamilton depression and so on. So let's talk about the biophysical health first. So pain scale, you can see different from the visual analog or the verbal numeric scale. It also captures the frequency. So you can see the algorithm is all very transparent. It's found on their website. A person have pain. If it is daily pain, then if it's mild, then it is 2. If it's serious, then it's 3. So as long as there's daily pain, you need to act on it. Less than daily pain, then it's either no pain or less than daily pain is just 1 point. So this is how we can use a pain score. If you intervene with, say, paracetamol, morphine, or physiotherapy, acupuncture, and so on, you can see the score improving, not just the vital signs of pain, which is moment to moment. This one is like whether the pain severity may remain, but it is less than daily, there's improvement. So you can actually start to see the score coming down. The pressure ulcer risk scale, there's no cutoff, but it is just a matter of telling you how high is the risk of pressure ulcer, and then you intervene, improve on the nutrition, improve on the functionality, improve on the pain control. Then you see whether the pain score will improve. Okay, if you really want to have a cutoff, I would say maybe moderate, 3 and above. Okay, so it's validated against Braden scale. BMI is very interesting. You see, in geriatrics, we use a lot of nutritional assessment. I gave you an example, M&A, but there are many other screening tools. But my colleague, Sister Fong, is here in the audience. She used to tell me, you know, Why screen at all? Everybody is at risk because we are in home care. Home care, everybody is at risk. So then what is really meaningful is BMI. See, this is a very new global leadership initiative on malnutrition. The way to screen for nutrition is still BMI. So your good old BMI is very useful. And what is interesting is for people older than 70, less than 22 is considered risk of malnutrition. So that's why if it's less than 22 for 70, InterRAI system is very up to date. It will trigger a nutritional care focus. This one will cover the next time we talk about it. So BMI less than 22 is considered not so good if for people 70 and above. Okay, so this is based on the GLIM 2020 standard. There's a phenotypic criteria, which is your weight loss more than 10, or BMI less than 20 or 22, or reduced muscle mass, plus a etiologic criteria, reduced food intake, malabsorption or inflammatory process, which is indicated by the ESR or CRP. But we may not take blood, but you can see this person taking less food and then BMI is less than 22. This person has got malnutrition. This 4 risk is found in checkup but not in home care. But I bring it up. Why? Every time I talk about InterRAI, people say, there's no 4 risk scale. Then how come my patient is at risk of 4 and the 4 care focus is not triggered, the gap is not triggered? So according to one of the very senior InterRAI fellow, her name is Catherine Burke. So those of you who use Burke Balance Scale, is from her. She's a physiotherapist from Canada. So she says that if you want to, if you have a very low threshold, almost all your patients are at 4 risk, then it's not very meaningful. So because of that, for a long time, the 4 cap was only triggered if there's a 4 in the last 1 year. No 4, even though you're very high risk of 4, then you don't have to consider that you have to focus on the 4 risk. You just have to do a general 4 risk prevention. But because of so many feedback, please give us a 4 risk algorithm. So this is very new, 2019. In checkup scale, checkup will be widely used by, you run an AAC, you do a community screening tool, CST, right? Those A, B, and C. The C, you do an InterRAI checkup, and you have this, you can benefit from this particular scale. So the component are the mode of locomotion, unsteady gait, cognitive function, and so on. There's 11 thing there. The nice thing is that you don't have to do this specially. Once you do checkup, automatically you got the first 4 risk algorithm. So cluster those in the similar group, and you find that in different parts of Canada is validated, all very consistent, 6 all linearly increase in the 4 risk. So if you score 3 and above, more than 20% chance of falling, first fall. So these are people who haven't fallen before. But if their 4 risk is like 3, 4, 5, or 6, you can actually start to act on it. So this is a very new scale and it's found in checkup but not in home care. Okay, I finished the biophysical health. Let's talk about the psycho-emotional one. So the depression rating scale is validated against Hamilton and Cornell scale for depression. You find that this, compared with DSM-4 criteria for diagnosing depression, the depression rating scale was 91% sensitive and 69% specific if you put a cutoff of 3. So this cutoff of 3 or more indicates very likely this person, 70% chance this person actually have depression. So we should actually assess. You see, depression is not to be diagnosed using any scale, GDS or DRS or whatever. It's to be diagnosed by a doctor trained in diagnosing depression. So the purpose of this scale is just to trigger for the doctor to take a look and make a diagnosis, DRS. CPS, the cognitive performance scale, combines information on memory impairment, level of consciousness, executive function, and so on. The scores range from 0 to 6, okay? So you can study how the most important bifurcation is at decision making. This is one of the in item C, in section C, decision making. If they are severely impaired, it is at least if severely impaired, it is at least 4 or 5, 5 or 6. Okay, then it goes by number of counting. So if it's not severely impaired, then you count it. But I don't have time to go into the details, but I like to share how do you interpret it. It's highly correlated with MMSE nursing home residents. And this is table that was like a the best find that I have on dementia care is from Reisberg. It's in the textbook. So you can see, okay, most of us in clinical work, we don't really know very much about CDR. GDS, which is developed by Reisberg, which is the origin of fast stage. GDS, we're also not familiar, but fast staging is widely used in our community services. Fast stage, okay, fast stage, we know, right? 3, you have dementia already. Sorry, 3 is MCI, 4 is dementia, and CPS 2 is dementia. And it corresponds with MMSE average of 19. 1 corresponds with MCI, mild cognitive impairment. So for those new to dementia, we know MCI is when there is actual psychometric evidence that this person has cognitive impairment, but it hasn't affected the functioning in the community. So that's MCI. Okay, so but this normal exam and subjective cognitive impairment, they don't have dementia. CPS score will be 0. Okay, fast stage 1 or 2, and then mild AD, fast stage 4 when they cannot plan a dinner party. Okay, so that's 2. 5, fast stage 5 is when they cannot choose proper clothing to wear. Fast stage 5, MMSE is about 15, CPS score is 3. Moderately severe, 6, beginning at when they have difficulty buttoning and dressing, all the way to bowel incontinence. CPS score be 4 and 5, MMSE average is 5 to 7. Then, of course, the very severe AD of 7, fast stage 7, CPS will be 6 maximum, and then MMSE is about 1 on the average. So this is how we interpret CPS. So once you do the InterRAI, you actually do not need to do the MMSE. But of course, sometimes when we have somebody triggered positive for dementia, cognitive impairment, to make a diagnosis, you cannot just rest on the score, right? You still have to identify what's the underlying cause. And MMSE is useful because you can also see which part of cognitive function is problematic. Is it the visual spatial, or is it the memory, or is it orientation, and also recognition. ABS, okay, aggressive behavior scale. 0 means no signs of aggressive behavior. 1 to 4 is mild to moderate. 5 to 12 is actually more severe. It goes by 4 items into InterRAI: verbally abusive behavior, physically abusive behavior, resistive behavior, socially inappropriate and disruptive behavior. Okay, so my own experience is I find people 2 or 3 caregivers already very stressed. So for me, my threshold for ABS is a bit low. If you're 1 to 2, 3, or 4, I would really focus on the challenging behavior to manage. Communication scale, it captures aphasia, either receptive or expressive aphasia. So the cutoff is 4. Once you have moderate impairment, that means you just add all these often understood, but usually you need to prompt them. Then you need to focus on communication. It's not common in the community where we refer to speech therapists, but maybe because we don't have the awareness of the importance of communication. So with this cutoff at 4, maybe you should invest on improving communication, either speech therapy, or just teach a family how to communicate better. Next, we cover functional ability. Okay, functional ability, there are many skills here. ADLH is really, it's based on hierarchy. It's a bit, I'll explain a little bit. You see, you can do ADL by using a checklist of like our Elder Shield, right? 6 ADL: mobility, transfer, feeding, showering, toileting, and dressing. Then 3 out of 6 moderately to severely require assistance. Then you pass, for severe disability. Whereas for ADLH, the concept is a little bit different. There are only 4: personal hygiene, toilet use, locomotion, and eating. You can see I will just annotate a little bit. So here, I'm talking about this one. locomotion and eating are considered a late stage loss. Most people, when they lose their ADL, if you recall, they cannot shower first, then they cannot dress, then toilet, right? And then cannot walk, transfer, then cannot eat. Okay, so usually there's a progression. So if a person cannot walk or cannot eat, most likely they cannot go toilet themselves or shower themselves already. So it's in this light that there is a hierarchy to it. So if I were to share with, if you were to look at this in details, only for this one, I like to invite you to read in details. Person, total dependence on 4 ADLs, then this is total dependence. If you use CFS, it's equivalent to 7, right? But if not total dependence, then we check, is it total dependence in eating or locomotion? If it is yes, that means this person is also quite dependent already. Most likely, the mobility, everything, you need a lot of support. Okay, so it's 5. Or if this person is not total dependence in feeding and locomotion, maybe it's extensive assistance in eating and locomotion. If it's yes, it is 4. Surely the other side of personal hygiene, toilet use also will be quite bad. Then if this one is a no, then at least extensive assistance in personal hygiene. Then if it's yes, then it's extensive. Okay. So I would say by the time they are here, most likely they will pass their Elder Shield or Cashew Life or your severe disability assessment. 3, also possible. 2, probably not. 1, probably not. Okay, so that's how I read the InterRAI ADLH. Let me just delete this. Okay. Okay. Long form. What is the use of long form? You see, ADLH has only 0 to 6. If you do some rehab and they improve, it may not show up because it's too broad, the jump in category. So they developed this ADL long form, which is 0 to 28, similar to the older version of Bartel, which is 0 to 20. And you find that they correlate with FIM and Bartel very well because of the higher number of categories. It's very granular. So very responsive. It's been shown to be highly responsive to detect differences in patients who receive home care by PT or OT, home rehab, okay? And then large degrees of improvement post-acute care. Effect size is comparable to FIM. And you can detect decline in physical function in cognitively impaired nursing home patients. So long form is useful for titrating and capturing the differences of your rehabilitation if you need to use it. The P and C for IDL is a bit confusing. P stands for performance, C stands for capacity. You can assess a person whether he has capacity in making a telephone call, going out to shop. Whether does he actually do? So how do you read this? C more than P, that means the capacity. Okay, in InterRAI nomenclature, higher score means worse, lower score means good. Different from Bartel. Bartel higher is better, right? So higher score, so if the C is higher than P, means he can perform better than, he can actually do better than what he's currently performing. It implies there is rehab potential. Maybe he's just depressed. Maybe he's just having no sense of purpose to improve. Maybe he has got some, maybe his environment is not conducive to go out himself. So if you see that C is more than P, you can invest in community OT, community PT, community rehab. Okay. P more than C, performance is better than their actual capacity, then this person is really pushing the boundary. Sometimes we see a person who is actually cannot walk, but he's like crawling and walking and full of fall risks. His performance is actually worse than his capacity. Okay, he cannot do. He's actually performing. Maybe I got confused. Performing better than his capacity. Performing better than his capacity is the other way around. I should put the, sorry, I need to put the sequence. Performing better than his capacity, then this person is really maybe having self-neglect. okay, I put a question mark here because seldom you see this, but performance lower than capacity. So P greater than C, okay, then this person have rehab potential. So change the sequence for this slide. Okay. Deafblind severity index. So it's about vision and hearing. So if you have a score of 3, both senses are either mild or moderately impaired. So 2, one sense is intact, the other one is severely impaired. So you can read it like this. So if you're 3 and above, both senses are you need some help. So vision, hearing are quite impaired. Okay. So people with dual sensory loss are more likely to be 85 years and older. And they usually may have moderate or severe cognitive impairment and impairment in ADLs. If an adult scores 1 or less on this scale, then this person should have a lot of potential for improvement, including the use of technology. Okay, so this is how you can make use of this particular scale. Social only one scale, which is the caregiver risk evaluation. This is quite new. I don't even know until Faiza shared with me this slide. So you don't have to ask the caregiver on a Zeri burden, but you go by other circumstantial evidence found in your assessment on the client, on the patient, not on the caregiver. Informal helper relationship, whether they live together, do they express feelings of distress, how many hours of actual care in the last 3 days, the cognitive performance scale of the client, and the depression rating scale of the client. Based on this, you can actually rate 1, 2, 3, 4. So 3 and above, high risk of experiencing, but I think moderate risk, you already should intervene to support the caregiver. Now, risk stratification. The first one is CHESS. You can see the Kaplan-Meier chart on the right-hand side. These are prognostication chart. You can see, okay, I'll use the annotation again. Okay, let's say nursing home. 180 days is 6 months. 6 months, they have passed away. If you go up, more than 50% chance of passing away is around here, okay, which is actually CFS as CHESS score 3. So in a nursing home, if the CHESS score is 3, this person has more than 50% chance of passing away in the next 6 months. This person should receive end-of-life care. So it helps you prognosticate and identify people. In home care, and this one, my own experience, it is like this. So a lot of patients are at CHESS score 2. 2 is around here. Because when they stay at home, usually they're quite stable. So 2. And then, so if you want to cut off at 50% chance of passing away within 6 months, sorry here, then you should really look at CHESS score 5. Okay, this is my own experience, not really evidence-based. In home care, I don't use CHESS so much. I go by dementia, stage 7, C and above, 1 episode of fever or severe urine infection in the last 1 year. So you should provide end-of-life care for them, or the surprise question. So, but CHESS score is quite useful if you work in nursing home. In home care, if you want to go by this, the population study is actually very big, then you can go by CHESS 5 or CHESS 4. Okay, so this is InterRAI in using for prognostication, CHESS score. So what does CHESS score comprise? It covers changes in decision-making, ADL status, change in function, health condition, end-stage disease, weight loss. So all these are found in the items. Maple score is very interesting. Okay, Maple score is, how do you use this? This is the way you, okay, recently I encountered a practical challenge. A community in Vietnam, right? They were doing assessment, risk stratification for population. And the level 3, which is equivalent to CFS 6 and above or 5 without a caregiver, is quite a lot. And then their resources are limited. Who do they go? So they needed something to prioritize. So this is how we can use it. Say in an AAC, and then you found somebody, CST is level C, you need to do assessment, then you do an InterRAI checkup. and then you have a lot of them, maybe 20 of them, and then you have only 2 or 3 case workers, right, or case manager. How do you identify who to go to? You could look at the MAPLE score. MAPLE score, there are 14 indicators. 1 and 2, they are quite stable. 3 is moderate. 4 and 5 are very high. What kind of risk do they have? It has been shown that individuals at the highest priority level are nearly 9 times more likely to be admitted to a long-term care facility, such as a nursing home, than the lowest priority clients. And in another paper, where this particular statement is extracted from, it shows that higher score means higher caregiver stress, higher chance of going to a nursing home, or going to hospital for social reasons, or the caregiver or a professional like a doctor or nurse who is very well trained, look at this person, feel that this person is better off elsewhere in an institution. So MAPLE score is that. And in my own experience using MAPLE score, home care clients usually 4 and 5. IHDC clients usually 3, daycare. Then the case management clients, those who are mobile and so on, usually 2 or 3. Okay. Derived scale is useful, I think, maybe for the regional health system. Okay. It predicts the risk of the person going to emergency department. So how do you use it? Oh, sorry. Okay, how do you use it? So for home and community users, so if you see this person having high diverse scale, you should quickly go and see them and stabilize their medical condition. Okay, so in primary care, say we are Healthier SG doctor, we collaborate with perhaps a case manager, from AAC or from other SCC, for example, and the diverse scale is quite high. Then as a doctor, I need to see this person early and maybe more frequently and review all the unstable medical conditions. Okay, so you can use the push method or the pull method. So push method is when the diverse scale is maybe high, 6, 5, 4, 3, 20. So the 6 quickly you have to see first. Push method. Pull method, case manager identify the high divert and do the care plan first. The VPS, when I first read it, I felt in Singapore it's not very needed because it is for disaster. So in a situation like Christchurch, in New Zealand, when they have an earthquake, they use their InterRAI information to identify seniors who are most vulnerable, and the items that sort of identifies are those on oxygen therapy or dialysis, live alone most of the time, no informal caregivers, have been withdrawing from activities of interest, very little social interactions or caregiver distress. So highest score is 0, 1, or 2. So 2 is the highest risk during a disaster or an emergency. 1 is moderate and 0 is no risk. But when I thought about it now, especially in the era of Active Aging Center 2.0, you're supposed to be in charge of a few blocks of HDB flats or even in the future condo. In the times of disaster, you identify those who are at risk. You should actually go and search for them. What kind of disaster? Climate change, fire. Recently, there are a lot of fire due to motorized vehicles charging at home, right? And you think about it now, the pandemic can happen again, and then you can identify the BPR tool to focus your attention on giving out N95 masks or face masks or provide some support for these seniors whom you're taking care of. So this from a population health perspective, not a doctor's. Doctors, we usually don't have to be so concerned, but we are living in a community of fast aging. So this is still very important for us to consider. So after all this has been said, I'm sure it is actually quite confusing. I'm going to introduce to you a cheat sheet. So first of all, the higher the score, the worse is the state. So how do you interpret pain? 1 is not daily, but can be severe. 2 is daily, and 2 is the trigger that you have to focus on the pain. QRS, higher the score, the worse. No cutoff score. BMI, less than 22 is risk of malnutrition if the patient is 70 years and higher. Aggressive behavior scale, 0 to 12. 5 or more is severe. 1 to 4 is mild, but my own experience, 2 or more is already stressful for caregiver. Communication scale, 4 or more triggers the communication gap. You should think of something to improve on the communication. CPS, 2 or more means there is dementia, most likely. Of course, you still need a doctor to diagnose dementia and what's the underlying cause to dementia. DRS, 3 or more means clinically depressed, very likely, 69% specific. Deaf blind index, 3 or more means you should actually have dual sensory loss. ADLH, okay, there's a whole range. It reflects the natural progression. ADL long form for granularity in response to rehab. IDL functional is an idea of frailty progression. I didn't show this because I think our clinical frailty scale is good enough. This IDL is InterRAI version of CFS, where it's a kind of a cumulative deficit frailty system. IDLC, what you think the person can do. IDLP is what the person actually can do. If the P is worse than C, that means the C is lower score, P is higher score, C is capacity, P is performance, then there is rehab potential. Care, risk of burnout, 2 and above, you should refer to case manager, social worker, community services, or AIC. VPR, it prioritizes your rescue mission. Okay, now we have about 10 minutes left, but is Faiza here? Faiza, would you like to comment a little bit before I do the quiz?
I
Faiza?
hi, sorry. I think I think Wai Chong is very clear. You made it quite simple. I think when we roll out the use of InterRAI, the reading of the outcome, because not everyone will actually need to be trained, right, to do the InterRAI assessment. So therefore, for people like, you know, the doctors, the PT, the OT, what I think Dr. Ng is trying to show is how then you actually read an InterRAI assessment output lah. So I think we are at AIC also developing a guide to read the CAPS and the scale, which we will be giving out to the providers as a manual or as a guide, so that, you know, it is also available already in the IT system. And the IT system also will have some like explanation in there, but we also would like to accompany it with a guidebook. So yeah, we are developing that when we roll out in the community.
Thank you, Faiza, and
Thank
thanks
you.
for joining us today. So Faiza is also an InterRAI fellow for Singapore, and she's leading the effort there's a big team in AIC to really make InterRAI more useful, more accessible, and really make an impact for the population gene. So let me continue with the quiz. Sure. Okay, so I just want to remind everybody of the CFS because the quiz involves CFS. CFS is very useful. It's very simple, very useful. So it gives you a picture of the older person. So the first quiz is like this. You look at this picture. What is the CFS level? So you can just type onto the chat. Then after 1 minute, I'll give you my thought, my answer. Okay, so everyone, you can use the chat and then type onto this. Then I'll say stop. Okay. What do you think is the CFS level? ADLH is 5. Higher, the worse, right? Anyway, it's written here dependent. Chest score is health instability. Higher means near end of life. In nursing home, 3 and above will qualify for palliative care. In community, 5. 4 if you put the timeline like 1 year. Communication scale, 3 and above, 4 and above means there's difficulty communicating, and this case is 7. CPS score, 2 and above, there is probably dementia already, and 6 corresponds with fast stage 7, and 4 and 5 correspond to fast stage 6. Depression rating scale, 3 and above, likely to have depression clinically. Pain, 2 and above means daily pain. MAPLE score, 5, it corresponds to caregiver stress and going to nursing homes. ABS, my own experience, 2 and above is already very thorough, okay? But 5 and above means severe ABS. IDL, C, capacity, total maximal assistance needed. Okay, now I've got 10 answers. Let's see. Okay, most of you think she's 7. Okay, I agree. I think it's 7. 8 is when it is totally dependent and yet have a high chance of passing away in the next 1 year. But the CHAES, the chest scale today in this case is 0, so probably not 8. So most likely it's 7. Okay, very good. Okay, most of you got the same answer as me. Okay, the next question, very challenging one. Okay, can this person make a decision? What do you think? Right, yes or no? Okay, can this person make decision? Yes, so where do you look? You look at the CPS, okay, and also comms. So communication, decision making, right? Remember our LPA training, it's like the person has some organic brain issue that can affect decision, right? Can understand information, weigh, retain long enough, weigh the pros and cons, and communicate. If they cannot communicate, it's considered cannot make decision, right? But of course, decision-making capacity depends also on what kind of decision you want to make. So generally, communication very bad, unlikely to be able to make decision. But also CPS 5, we know that CPS 5 correspond to fast stage 6. That means ADL very impaired, fast stage 6. Most of the time, fast stage 6, based on experience, they can't make a lot of decision. Maybe they can make decision like I want to eat or not, but more complex decision they cannot make. Okay, very good. All of you answered same as me. Okay. Do you think she can qualify for ElderShield or CareShield Life? Looking at this. Okay, so where do you look? We know those of you trained in severe disability assessment, you know there are cognitive, there's also 6 ADL functioning, moderate or severe, or more than moderate assistance. So you look under ADLH. I mentioned just now 4 and above most likely qualify. 3, you have to assess, but also likely qualify. Then CPS, if you're very severely impaired, you need prompting all the way throughout your ADL, most likely qualify. So many of you put yes, which is same answer as me. Okay, so this person most likely qualify for ElderShield or CareShield Life. The next one, would the caregiver be stressed? Okay, you type yes or no, caregiver. Okay, I didn't put any caregiver information, but there are certain things that are very indicative. MAPLE score is very high, it's 5. ABS, aggressive behavior scale, is 3, is moderate. Okay, and the ADL is very intensive, a lot of heavy lifting. And communication is very severe, and the dementia is quite severe. And there's also some depression, but it's not like clinically depressed. So most likely the caregiver is very stressed. Okay, the next one is based on your experience in the community already. Okay, the last question on this particular case is, if she is not living in a nursing home, what kind of community services do you think she's likely to need? Just type, okay, what do you think she needs, this patient? So many of you are, we have got 30 to 40 doctors here. Many of you are community aged care physicians. Some of you are GPs. And then I see Shireen is laughing. A maid, yeah, you really need a maid. But you know what? I mean, many of you have experience. Hiring a maid is very difficult. I recently have a conversation with a friend. made from Burma, made from Indonesia, made from Philippines are different. Okay, and then you need to know how to manage the foreign domestic worker also. Norita said dementia day care, yes, it will help. Dementia day care, Rosita said dementia day care. And then IHDC with the helper, yes, but I understand IHDC is sunsetting, right? Helper would be very useful, but a lot of family, they really find it difficult. So now they may hire like home personal care for long hours from Active Global, from Homage. Befrienders maybe to the caregivers. But Kelvin talked about befrienders. Actually, there's something very important here. A lot of senior with challenging behaviors is because they are very insecure, maybe very bored. There's nothing to do at home when nobody is at home. So if we can have a service where we either deliver activities of meaning with them, or we bring them out to a dementia day care, it will improve. So befriender to the patient may be difficult, but activities and to engage the patient may be needed. Meals on Wheels, yes, but if the caregivers can make meals, maybe not necessary. Social worker to follow up, yes, there's a lot of social work involved because the caregiver is very stressed. And a lot of time they need some guidance on navigating the system, right? Home care, community care. Home care may be needed because to go to a daycare center, the senior, a lot of time they resist. So you need home care, community care, home personal care. And home care is not just medical, you need nurses because a lot of time is how do you coach and mentor the caregivers. Case management is indeed very important because it's a complex case. You need case management. Okay. Then home therapy, CCMS. Yes, CCMS is home. Sister Haryati, thank you, CCMS. Sister Haryati is from Taiwan. Welcome. So CCMS is very important because it's a complex case. Okay, so I have got 2 other cases of quizzes, but I think we have only time for this. So I shall close the chat. Let's go on to, I got this case and another case. Maybe we can reserve it for other time. So this is a resource in CAIHI. CAIHI stands for Canadian Institute of Healthcare Informatics. I actually have a link, but if I link here, I have to stop share and share the screen again. So I won't do that since Faiza already said AIC have also prepared something like this. We need a kind of a job aid. Maybe I show you how it looks like. So let me click on to this. I will stop share and share again to share with you the website. Cool. So this is a job aid from Canada. So you can see it looks like this. Oh, ABS, what does it mean? ADL, IDL hierarchy, ADL long form, performance, short form, chess, communication. It can share with you how to interpret. Okay. So you can, it's free for everybody to download anyway. So this lecture will be on YouTube also, HNF channel. Okay, so this is my final 2 slides. It's a summary. The InterRAI instruments are comprehensive, covering most aspects of functional, clinical, cognitive, mood, socioeconomic dimensions of assessment that are required for meaningful care and care planning. Okay. Just now I talked about a senior, what is really important to him. That is in the next month's lecture on CAPS. But what is more important about person-centered care is actually your relationship. No amount of standardization of instrument can help you, can replace your relationship. So the assessment is not whether it doesn't make you more person-centered or not, but it's about how you communicate with the client and the caregiver. A prior InterRAI assessment conducted by a trained case manager or nurse, allied health professional, or just a trained person can reduce the time spent by the doctor for your CGA. By reading the assessment, the scales and the caps, a doctor can have a fairly good picture of the degree of frailty and the areas of care needs. So as I mentioned, you look at it, you know roughly CFS what are the areas, how stressful the caregivers will be, will it pass for ElderShield, what kind of community services they will need. The areas that are not covered are the medical diagnosis and treatment. There are some symptoms of acute illness and complication of chronic illness is not captured here. Okay, for example, fever. For example, the person is having a lot of phlegm. It's not captured. Diarrhea will be captured, but the purpose of InterRAI is not so much acute. It's really for long-term developing a long-term care plan. So a doctor, sometimes when you see a patient, you still have to ask for any acute illness. Monitoring and treatment plans related to chronic disease management are also not always covered, like blood pressure, HbA1c, they are not covered. Vital signs is not captured in InterRAI. You still have to measure and do the clinical examination. Specific decision-making capacity. You have a general decision-making capacity, but the specific one to elect a donee, LPA, the doctor still have to do. Reviewing the medication, the doctor have to do. Okay, so the role of a doctor in the face of InterRAI. For me, I want when if we use InterRAI, the doctor's assessment can be shortened a lot. So it's similar to how we practice as a doctor now. We usually go to NEHR to look for the latest discharge summary. But in the future, patient need not touch the hospital in order to have home care. You may have to start from scratch. So where do you go if they are not admitted? No summary on NEHR. So you look at the InterRAI assessment. So also even NEHR is all medical, hospital kind of assessment. So if say a community case manager or a nurse have already done the InterRAI, we should read it to have a picture of the patient and identify what are the areas we need to focus on. Making diagnosis is necessary. Behind the symptoms, behind the CPS 2 or 3, no diagnosis of dementia. The doctor's duty is to diagnose the dementia and diagnose what's the underlying cause. Is it Alzheimer's, vascular dementia, frontotemporal, or is it your Lewy body? So we still have to make the diagnosis. And the fall risk is high. We have to identify what's causing the fall risk behind the scales and the caps. Depression also, we need to diagnose. Prognostication. The chest scale may be, as I mentioned in home care, chest scale usually is 2 or 1 or at most 3, but we have to prognosticate based on our clinical experience, on life expectancy, as well as rehab potential. Rehab potential, InterRAI can help us. InterRAI, the cap on ADL and IDL, it interface with the cognitive function of the person. But when we look at the person, we talk to the person, we can also sense the motivation of the person. We can also identify rehab potential. That's the doctor's duty. Disease management decisions. Based on the whole picture, we can see what kind of treatment is meaningful, what kind of treatment is over-servicing. Preventive health decision based on the prognosis, based on what is meaningful and priority of the patient and the caregiver. We can recommend, do you need annual blood tests? Do you need to go for colonoscopy, for example? So we help them to make preventive health decisions. Vaccination. Medication review is very, very useful. For a doctor, when I ask Len Gray, he's a geriatrician who's an InterRAI fellow, I say, what's the difference between InterRAI assessment and the doctor's assessment? If InterRAI is very thorough, then what's the role of the doctor? He says the doctor still has to do diagnosis, prognosis, and review of the medication. Okay? Because he's a geriatrician, he knows polypharmacy is very bad. So doctors can decide, what are the things we can remove. Fiduciary assessment, not just your Elder Shield, Care Shield, your disability assessment, your LPA and so on. But doctor, because of the professional act, we can shoulder a lot of risk, whether to go to hospital or not, go to A&E or not, or cancelling the SOC appointments, or reducing the medication. Doctors have that kind of position to de-prescribe, to stop certain unnecessary SOC appointment, or even recommending to go to hospitals or not. So we can shoulder the risk. Clinical communication is the last point, but it's perhaps the most important point. You find that a lot of data, a lot of information, how to make sense of it. How do you make good decision from it? And what do you say to the patient? A lot of time is trust. In the face of AI, technology, and so on, trust is the most valuable commodity. Quoting who? PM Lee. So trust is really important. So if you can have that, then you actually communicate with the patient about what is the current issue, what is our priority, what are the things that we no longer make a difference, how should we navigate the system. So this clinical communication is very valuable, and coming from a doctor is very impactful. Of course, nurses also can do this, but sometimes certain things you want to hear from the doctor. Okay, so I think that's all for me. May I also invite Faizah to comment? Faizah, you have anything to add?
I think, I think that's very comprehensive enough. I think it will be, I think there's a lot of home care providers in this seminar. So I'm quite excited to inform that, you know, we will be getting in touch on the implementation of InterRAI in the community. We will start as early as 1 year before the rollout to start the engagement with everyone. So in our engagement, we talk about, you know, the training, we talk about how to use who to send for training. We'll talk about some of the support structure that we will be embarking, and then forming of the community of practice. And also developing the care plan like what we have done for nursing home. We will embark on the same journey. And I'm actually quite excited because it will be more for community care, not just the institution. So I've always got my heart at Comcare. So I would really wish everyone, you know, the cooperation together. I think one last sentence I would like to say is that the journey is with everyone. It's not just AIC journey, nor is it MOH journey. And the journey must come together but from provider and then work together with us. Yeah. So we will really need everyone to handhold us together. Yeah.
Thanks, Lisa.
Yeah.
And from me, I feel this is really is very useful. It's yeah. So anyway, I also like to open to questions and answer. Are there any questions from the floor? Hui asked a question about the case studies. I'll probably make use of them in the next section when we're using case study to do care planning using the CAPS. So anyone with any questions for us? If not, we have overshot by 12 minutes. Okay. Okay, so maybe we can end. Christina, would you like to have the last word?
Okay, thank you very much, everyone, for sharing your this afternoon with us. We want to look forward to having you at our next webinar, which is the first Saturday of June, and also at the same time invite you to participate and come down for our Age Well Symposium on the 11th of October. Those of you who have active aging centers, please feel free to contact us. We will be happy to work with you to try out the care assessment and referrals so that we can ease some of your frail patients into the home care services that are currently already available. So that's our appeal to you, and thank you again for joining us this Saturday afternoon. See you. Have a great weekend. Thank you very much, Liza.
8th of June, Christina.
Okay, one more question in the Q&A.
Yeah, it's 8th of June is the next webinar. Okay. How do you see InterRAI rolling out an AAC in Singapore? Don't know yet, Faiza.
I think we are still working out with MOH with a few things that is, you know, that the community care sector is a moving piece. You all heard about the Age Well SG and then how they are going to start bundling some services together. So AAC will also be involved and InterRAI will be used. So there will be more announcements coming up in a couple of months, and that's where AAC and InterRAI will gel up. Yeah.
Yeah.
Yes. So for the nursing homes, it will be used in all nursing homes in Singapore. Yes.
Yeah.
It will also be rolled out in home and center-based care.
Yes.
It's after the nursing homes have implemented it.
Yes.
So in terms of the timeline, maybe Faiza, you just want to give a quick reminder.
Yeah, okay. So nursing home is going to be rolled out in October 2024, which is actually just 4 months down the road or 5 months. Training at the sector for all the nursing home have started. We are doing it in 3 phases, in 3 waves. And we also have early adopters of nursing home who come on board even before the rollout. So some of the about 18 nursing homes have done a lot of assessments already. So after the nursing home, we will give about 1 year for nursing home to stabilize. And in 2026, we will roll out in home and community care. But a year before that, we will start engaging everyone on the plans for training and so on.
Yeah. So in terms of the AAC, most likely only the very frail patients who are CFS 5 and above, who require home care will be using the InterRAI to assess their resource needs, and then we can plug them into the community-based services like Home Nursing Foundation or various other home care providers.
Okay.
Okay, thank you so much.
Okay,
Goodbye.
bye-bye.
Great weekend, everyone. See you next
Bye-bye.
month.
Bye.
Bye-bye.